Hello guys, and welcome to another anatomy review. Today we're going to look at the nervous system. This is going to be the first video in a series of videos, as well as some lab videos that I'm going to include in this as well. So, aims and objectives you can have a look at in your own time. I just want to start off by looking at the actual divisions of the nervous system. So the structural nervous system is formed by the brain and the spinal cord, and then of course the peripheral nervous system is all of the various peripheral nerves that we're going to see going off to the limbs, which we're going to discuss. Now the functions, the physiology behind it, we've got somatic nerves, somatic nervous system, the SNS, and then we have the autonomic nervous system, which we're going to discuss in relation to the general visceral efferents, afferents, general somatic efferents and afferents as we go through. So let's just have a look at the central nervous system. As we've said, central nervous system consists of the brain and the spinal cord itself. Then we have the peripheral nervous system, which include the cranial nerves and the spinal nerves, which are going to come out and form the various plexi, which are going to innervate our limbs. So the actual organisation of the nervous system, we have the CNS, the brain and the spinal cord, and then we have what we describe as efferent and afferent divisions. So efferent divisions are the motor output, and the afferent divisions are the sensory information going in, and this is derived from both somatic and visceral. So somatic is going to be your musculoskeletal system, and visceral is going to be everything which is autonomic or viscera, such as vasodilation, vasoconstriction, which we're going to talk about in more detail shortly. So for now, it's just important to remember that we have afferent divisions, which is sensory, and an efferent, and if you just remember the E, engine, this is our motor division, and of course everything going in has got to have somatic and visceral, and then everything coming out has got to have somatic and autonomic as well. So the peripheral nervous system, we've got axons and cell bodies outside of the CNS, and then the peripheral nerve itself is a bundle of axons which is held together by a connective tissue sheath outside of the central nervous system. There's 12 pairs of cranial nerves, and there's 31 pairs of spinal nerves, and then a ganglion is a collection of nerve cell bodies outside of the central nervous system, and this is an important point because we're going to consider something called the dorsal root ganglion, which we can see here. So the dorsal root ganglion, dorsal as in it's on the dorsal aspect. We can see as well we have a dorsal root sensory and a ventral root motor. So we have the motor input and the sensory output, and this important dorsal root ganglion, which we're going to look at in a little bit more detail. So in order to understand or comprehend the nervous system in more logical terms, it's important just to be able to relate it to the vertebral column or the spinal column in general. So we have a cervical region. So of the 8 cervical spinal nerves, the first 7 emerge superior to their corresponding vertebra. So as you'll remember from your basic anatomy, these first the cervical region, we have this superior emergence of the corresponding nerves, and then C8 emerges between the vertebrae C7 and T1. We also have a thoracic region, and all of the thoracic spinal nerves exit below their respective vertebra, but still above their corresponding intervertebral discs. And then the lumbar region is the same as the thoracic. So it's only the cervical region that we have this difference of the emergence of the nerves. So please just pay note. In this image we can see cross section here. We can see the cervical region, thoracic region, lumbar region, sacral region. We can see where conus medullaris is where the end of the spinal cord is, around the level of L1, and then of course the chorda equina and the filame terminal, the different regions, which we're going to look at in our lab dissection as well. So what is a spinal nerve? Well, a spinal nerve is a functional component of the peripheral nervous system, or the PNS. The typical spinal nerve consists of motor efferent fibres, so remember efferent engine motor. that arise from the cell bodies located in the spinal cord, and sensory afferent fibres, which is of course the sensory part, that arise from cell bodies located on the dorsal root ganglion of the spinal nerve itself. Thus, this is an important point, the spinal nerve is a mixed nerve. The spinal nerves themselves are bundles of neurons that are wrapped in connective tissue sheaths, which we're going to talk about these sheaths and the importance of nerve conduction as we progress through these videos. And each spinal nerve contains 3 layers of connective tissue: epineurum, perineurium and endoneurium. So here we can just see the nerve trunk, we can see the different actual sheaths, the endoneurium, we can see the nerve fibres, and we can see the sensory neuron itself and the motor neuron. So the sensory neuron and the motor neuron, of course, transmitting these sensory and these motor responses. So let's just have a quick look at a schematic for a second here and just see how the sensory and the motor paths work in relation to the somatic system. Okay guys, so what's important to remember about the nervous system when we discuss in relation to the general visceral efferents, afferents, general somatic efferents and afferents, it's important to remember that the musculoskeletal system, so the part of the body that we can control, is somatic. So we have somatic efferents, which is going to be a motor response, and somatic afferents, which is of course going to be our sensory response. So what we can see here is an example of where the sensory receptors in the skin, for example, free nerve ending of the sensory neuron, if we touch something like a hot plate or touch something sharp, we get this afferent signal which sends up, and we go via the dorsal root ganglion. We have the sensory axons in the cell bodies of the dorsal root. So all of this sensory information is going to track up, and depending on whether it's going to go to the higher centres or not, will be a local reflex response, which we'll discuss later, depends upon what part is being innervated. Then of course we've got the somatic efferent response, which is going to actually fire up the neuromusculoskeletal junction to make a musculoskeletal action, such as removal of the hand from the hot plate. So just looking at this in a little bit more detail, so we have these sensory afferents of the spinal nerves. Remember guys, afferents is the sensory part, A for effect. So we're conducting sensory information from the tissues of the body or the peripheries to the central nervous system, and then we're doing this via this dorsal root ganglion, DRG. I just want you to just take a quick note at this image here. So on the side here we can see a somatic response, musculoskeletal response, sensory information going up. But don't forget, we also have to remember general visceral efferents and afferents, and we can see this coming along, communicating with the sympathetic chain and going via these grey and white rami communicant pathways, again following eventually the same dorsal root. But it's important just for now that we're just aware that within any cross-section, so any cross-section you look at within the body, whether it be an arm or a leg, you're going to have this musculoskeletal compartment, which is going to be general somatic efferents and afferents, but also you're going to have viscera in there, such as veins and arteries, which can vasodilate and constrict, etc., which are going to be controlled by this general visceral efferent and afferent pathway, which takes a slightly different route, which we will start to look at shortly. So the motor efferents, the spinal nerves, the engine, the motor response, is the conduction of the motor information from the CNS, from the central nervous system, to the periphery via the ventral roots. So of course here we have the ventral roots, and the ventral roots, if it's a somatic case, we're going to have this somatic motor response, such as removing the arm from the offending hot plate or the stimuli, or in the visceral response, we're going to have a general visceral efferent and afferent effect, or in this case a general visceral efferent effect, a motor response upon the viscera. So in this case we just have an artery, an example of an artery sending a visceral efferent message, and then getting the efferent response. So whatever it needs to do, vasodilation, vasoconstriction, all covered under the autonomic.
So the functional compartments in the peripheral nervous system, let's just look at these in a little bit more detail and just go through this. And as I say, there's a few videos that are going to follow on to break these concepts down, and also there is a lab component to this as well. So we'll look at the actual CNS and the PNS in the cadaver. So we have general somatic afferents, GSA. This is sensitive to pain, temperature, touch, proprioception. Remember, this is somatic, musculoskeletal. Then we have general somatic efferents, GSE, which is the motor impulse to the skeletal muscle. So this is the ultimate engine response. Then we have just general visceral afferent, GVA, sensory impulses from the viscera, organs, e.g. distension of the gut, etc., etc. Then we have the motor response, the general visceral efferents. This is autonomic fibres, and this is transmitting motor impulses to smooth muscle, cardiac muscle and glandular tissues. But we also have special somatic afferent and efferent, which we're going to just look at as well. So we have the sensory impulses of vision, hearing, equilibrium and our cranial nerves, which we'll look at in a later lecture. And then of course we have the special visceral afferent part of that, which is the transmission of the smell, taste and the unique senses derived from the CNS. So how are spinal nerves formed? Well, spinal nerves arise from the spinal cord via the rootlets, and these converge to form two nerve rootlets at each level of the spinal cord. This is, of course, is going to be one at each side of the body, because we need to get this innervation not just unilaterally but bilaterally. The dorsal root ganglion, or the DRG as it's often referred to, is the accumulation of the sensory nerve cell bodies of the spinal nerve, and no synapses take place in this place, or in the DRG. The dorsal and the ventral roots unite in the intervertebral foramen to form a mixed spinal nerve that immediately divides into a dorsal and primary rami and the ventral primary rami, so we can have communication to the front and the back of the body. So let's just have a quick look at the schematic here and see some of the important features that we're going to consider. So here we can see a mixed spinal nerve, and as we've started to mention, this is a mixture of the dorsal and the ventral root coming together. And of course we're going to have the grey and the white matter, so we can see the grey matter and the white matter, which we're going to talk about in relation to cell bodies, and also within we're going to talk about the homunculus and the motor cortex and the different regions of grey and white matter and why this is so important, as well as motor neurons, and also discussing the importance of understanding about upper and lower motor neurons in disease or pathology such as upper and lower motor neuron disease. So in this image we can just see a dermatonal region, and that is a region of skin that's supplied by a single spinal nerve. So here we can just see an image of the different levels, C2, C3, 5, and then T1 down to T12, and then the different regions L, S, etc., etc., which actually makes a lot more sense when one looks at the animal model, because in the bipedal state it is separated slightly differently, but when we're in the quadrupedal state on all fours, as we were originally, these line up pretty much precisely, so it's easy to kind of see as a cross-section when you see it on a quadrupedal model. But of course, as we've developed and we've become bipedal, we see this dermatonal spreading the way it is. And this is important. Why? Well, this is important because if we have any of the affected nerve regions, we can have things such as herpes zoster, which are affected. And you can just see in this image here, we've got the affected nerve, and then the following shingles rash because of this de-innervation or oversensitization to the area. And again, they're following the pattern of dermatomes. You can see the shingles on the face via the mandibular nerve. Dermatome patterns are very important because they are going to allow for an understanding of not just the single spinal cord level, but also the superficial branching sensory innervation to the skin, the dermatonal regions, which we're going to talk about during our lab component as well. So talking about that, it's important that we first look at the spinal cord itself and look at the different regions that we're going to see in our dissection. So we have our lumbosacral enlargement, which we can see on our cadaver. We have the conus medullaris at the region of L1, L2, the chorda equina, or the horse's tail as it's known, and then the filame terminale, and this is covered in pia mater, and we'll talk about that as we progress through. And it's just important to understand the levels in relation to time. So as we age, during newborn to the first year, we can see that the conus medullaris is right down, and then as we slowly get older, this comes up, and that's going to be important when we talk about things like spinal taps and clinical areas such as that. So let's just look at some of the important areas that we're going to look at in the cadaver and identify on our specimen as well. So what we can see on the drawing first, we can see the actual spinal cord itself covered in the dura mater. And remember, dura is tough. Dura mater means tough mother. So the dura mater is the outer layer, the tougher layer. Then the next kind of layer that we have is the arachnoid mater, which comes from the word spider mother, arachnoid mater, because it looks something like a spider's web. And then the very deepest layer we have the pia mater, and then pia mater refers to loving mother, the close covering, and it refers to this very, very deep layer, this pia mater covering the spinal cord itself. And we can also see the spinal blood vessels and the dorsal roots, in this case of the sixth cervical nerve, and also the ventral root of the sixth cervical nerve, which we're going to look at in our cadaver as we start to complete and go through with our laminectomy and disarticulation. So as I just mentioned briefly, it's important to understand where these levels are, L1, L2, and the conus medullaris, and where the chorda equina is, because during clinical practice, one of the things that you may well come into contact with, you will come into contact with, will be that of the lumbar puncture or the spinal tap. And the reason for our understanding of anatomy at this point is to reduce the risk of damaging the spinal cord by presenting the needle in the least likely area to cause damage. And we can see here L1, L2, and below, as we come down from the conus medullaris, we can see the chorda equina and then these filaments. So when the needle is placed, it's not going into like a direct structure, just such as the lumbosacral enlargement. You're kind of going between these smaller areas, the horse's tail, the filaments. So let's just look at this anterior view and look at just how the whole of the spinal cord communicates with the dorsal and ventral root, how we communicate with the sympathetic chain, and how we're going to get GVE, GVA, GSE, GSA to their various places. So first of all, immediately after the motor and sensory fibres merge to form a spinal nerve, the spinal nerve divides into a ventral ramus and a dorsal ramus, as we discussed, which is going to go anterior and posterior region of whatever region of the body it is, whether it be the thorax or the abdomen. Then the dorsal rami segmentally innervate the deep back muscles with this motor response, and the skin of the back with this sensory information, so we can feel sensation on the back. Ventral rami distribute to the extrinsic muscles of the back, and the ventral muscles and the overlying parts of the dermatome, which we've discussed. As the dermatome becomes damaged, this could be due to something such as intercostal nerve block or something like that. During a chest drain, if the nerves hit, this nerve region can be damaged. So let's just look at the schematic again. We can see the white matter and the grey matter, and we're going to talk about the importance of the grey and white matter in relation to the nerve bodies and the nerve bodies and the cells, and the axonal communications. And then here we can see the dorsal and the ventral rootlets of the spinal nerve. And the ventral and dorsal rootlets are going to eventually form a spinal nerve, which is going to be called a mixed spinal nerve. And we're going to see this dorsal ramus of the spinal nerve going dorsally, and then we're going to have this anterior communication as well with these rami communicans, which are going to give rise to what we call the sympathetic trunk. And you'll remember, guys, that the sympathetic trunk is very much like a ladder, allowing us to go from vertebral level to vertebral level to carry the sympathetics. So remember the parasympathetics, as we've discussed, is the vagus nerve and S234 coming up from below, and then forming these various areas in which we're going to get innervation. Vagus nerve, of course, coming down, recurrent laryngeal, giving off the esophageal branch, cardiac branch, down to the gut, giving off, but all the way communicating from the up above and down below, all the way down the spinothalamic tract. So we have this important configuration, which we will break down into simpler concepts as we go through the next few lectures. So the dorsal primary rami supplies, got the synovial joints of the vertebral column, the deep muscles, intrinsic muscles of the back, and the overlying skin. And the ventral primary rami, anterior and lateral regions of the trunk and the upper limbs, and the VPR and DPR also carry postganglionic sympathetic axons for blood vessels, smooth muscle cells and glands. So this is important as well, because you've got to remember that although we're looking at the body wall, we can see the cross section, we can see the dorsal root, the dorsal and the ventral root, and then we've got our anterior and posterior division and sympathetic chain lying bilaterally along the vertebra. And then of course we're going to have our branching off to the anterior region and of course the posterior region, so we're going to get sensory information into the back, and then motor information to the back, as well as sensory information to the front and back. But also remember how important we do have all of the visceral information that is going to be communicated via this pathway as well. So it's not purely somatic. We have general visceral efferents, afferents, general somatic efferents and afferents within this. So just here in this dissection we can see a deep dissection of the suboccipital region and some of the superficial intrinsic back muscles that have been removed to reveal the suboccipital muscles and the upper cervical dorsal rami. So we can just see how that these upper cervical dorsal rami are coming up right to the back for suboccipital nerve. This doesn't have any cutaneous branches. The C2, the great occipital nerve, and C3 is just C3, C4 and C8, as we can see, down to C4 here, in the posterior triangle. So the ventral rami, we have the cervical plexus, the brachial plexus, the thoracic intercostal nerves, the lumbar plexus and the lumbosacral plexus, all of which we shall look at in relation to movement as we continue through our lecture series. So the cervical plexus, let's look at that for a moment. This consists of the ventral rami of C1 to C4 spinal nerves. The peripheral nerves emerging from the cervical plexus provide cutaneous innervation to the back and the head, shoulder and upper thoracic region. They also provide motor innervation to muscles of the anterior neck and the diaphragm. Now the brachial plexus, which we were talking a lot about, and the lumbosacral plexus in relation to injuries of these and mechanisms of injuries to these, consists of the ventral rami of C5 to T1 spinal nerves, C5, 6, 7, 8, T1. Peripheral nerves emerging from the brachial plexus provide cutaneous motor innervation to the skin and muscles of the upper limb. The intercostal nerve consists of the ventral rami of T1 to T11 spinal nerves that course within the intercostal spaces along the costal groove that associate ribs to innervate the skin and the musculatures of the intercostal spaces. And then these are something that we're going to talk about when we talk about chest drain placement in relation to between ribs and where the vein, the artery and the nerve sits. So the lumbar plexus consists of the ventral rami of T12 to L4 spinal nerves. Peripheral nerves emerging from the lumbar plexus provide cutaneous innervation to the skin and lower abdominal wall, peritoneum, anterior thigh and medial thigh. They also provide motor innervation to muscles of the perineum, anterior thigh and the medial thigh. And then we have the sacral plexus, and then we'll talk about the lumbar sacral plexus together, but it's best to just learn them initially just separately. Then the sacral plexus consists of ventral rami of L4 to S3 spinal nerves. Peripheral nerves emerging from the sacral plexus provide cutaneous and motor innervation to the skin and muscles of the lower gluteal region, posterior thigh, posterior leg and foot. So, where does the CNS receive information? Well, it receives it from two sources. We've got the external world around us via special senses, via interactions with the body, or the body known as soma, afferent sensory modalities communicated by the spinal and cranial nerves, modality and location specific and stereotypic. The internal visceral world, which is a little bit out of our control, the heart, blood vessels, lungs, digestive tract, etc., we have afferent modalities, do not normally react consciously. So these are things that we don't really control. We can't control our vasodilation and vasoconstriction and heart rate, essentially. Then the brain responds to the information via the somatic efferent motor system, which is communicated via spinal nerves, which we've talked about and we're going to look at in more detail, and the autonomic nervous system. So, let's look at the afferent information from the periphery when it's conveyed from the CNS via a first order neuron. So what we have here is, this is representative of the CNS, the central nervous system. Then we have the PNS, the peripheral nervous system. This would be the dorsal root ganglion, known as the first order neuron. And here we have the skin, the mucosal joint of the muscle. So let's just look at why these different order are important. So if we think of an afferent pathway for a second, this is a sensory pathway going to the sensory cortex via the homunculus, which we're going to talk about. If we think of the skin, the mucosa, the joint muscles, we have this peripheral nerve, this myelinated peripheral nerve, and we have our dorsal root ganglion, which is going to be our first order neuron. The second order neuron that we're going to come into contact is going to be within the dorsal horn. Then as we track up via the thalamus, we have our third order neuron, and of course this is going to communicate with our sensory cortex and homunculus. And this is relevant because when we talk about motor neuron disease, we talk about upper or lower motor neuron disease and how it's affected. So when you hear the term upper or lower motor neuron disease and the pathologies related to that, you're actually imagining somewhat of a diagram such as this, where you must think about which part of the circuit, as it were, has been affected. So here we can just see in this instance we have Albert Einstein here, and sensory stimulus to his left region or his left arm. This is going to go via the dorsal root ganglion. We're going to have the sensory information, which is going to be conveyed to a region in the homunculus. So the homunculus, as you can see here, here's the foot of the homunculus, the leg, the knee, the trunk, the face. The arm, and then here's the face and the lips. So all of the homunculus is in relation to the sensory and the motor control that we have, and it's contralateral, so it works on the opposite side. So if you have a stroke in your right hemisphere of the brain, in the region of the hand, say this region, it's going to affect your left hand, because it's going to be contralateral, or vice versa. So it's just important to have an understanding of how the signals work and how they are contralateral. So that's why when we see patients that have had a subdural, subarachnoid hematoma, or suffering from dementia, etc., various other neuropathologies, we get these contralateral effects. So it might be the right hemisphere that's affected, but their left limb may be damaged. So distinguishing modalities, sensory transduction. So there are 5 clinically relevant sensory modalities: touch, pain, temperature, proprioception and vibration. In general, each modality is associated with a specific transducer that is conducted to a specific subset of first order neurons. Therefore, each dorsal root ganglia contains many subtypes of first order neurons. So it's important just to be aware that these paths, how important these paths are, and the various differences that they have. So lower motor neurons connect to the CNS to striated muscles in the periphery. So in this case we can see the CNS and then we have the PNS here, and we can see the input of the signal, dendrites, signal transmitting via the myelin sheath. And we're going to talk about myelin as that myelinization and demyelinization in relation to sense and nerve impulse, and why myelin is important, so important, and why certain areas in the body have less myelin than others in relation to the transmission of signals. So the activation of specific muscle groups is regulated output from the motor cortex. So this is going to be the motor response to the sensory information in. And again, we have this contralateral communication via the homunculus, so the different regions within the brain. And of course, just remember guys, you can see here on the outer region, this is all the grey matter and then the white matter, which is going to have all the axonal communications. All of the dark matter, or the grey matter, is where the actual information is stored. It's a bit like a CD. All of the information is stored on these peripheries. And on these peripheries, we discuss something called cortical space. And cortical space is what is related to the amount of information needed to perform a task. So if we imagine a hand for a moment, and you play the piano, and you play it well, you're going to need a fairly decent amount of cortical space to be able to remember these patterns and store these patterns. For more broad, refined movements such as bending the knee or bending the foot, there's a smaller amount of space that's required. But every movement that we do as human beings is stored within these areas, and we can talk about cortical space later on, but it's just a nice way of thinking that everything that we do, and the more complex our processes, the more amount of data, as it were, if you think of it in computer terminology, we need. So we can just see how the motor response transmits, and then eventually, going via the brainstem, we're going to go via these corticospinal tracts. Then we're going to send our sensory information to the contralateral part. So again, the same way as we said with the sensory information, motor information is going to be contralateral. So again, if you have a region in the primary motor cortex that's damaged on the right side, it's going to affect the left side of the patient. And this is very important for your physical diagnosis as well when we discuss the correlates and the clinical correlates. So the autonomic nervous system, let's just look at that. Now here we can see the CNS, this is going to be the PNS. In this region we have the brain and the spinal cord. This is going to be the region of the hypothalamus. Then the spinal cord, we've got these preganglionic neurons, so before the ganglion. Then we fuse with the ganglion, and then we have postganglionic neurons. So when we talk about pre and postganglionic, we're very much talking about before we fused with a ganglion. Then we have the postganglionic neuron, which is going to give rise to communication with the skin and viscera, the smooth muscles, the blood vessels and the glands. Comparisons of the autonomic and the somatic nervous system. The autonomic nervous system, chain of 2 motor neurons, preganglionic neuron, postganglionic neuron. Conduction is slower due to a thinly or unmyelinated axons. So here we can just see the difference between the two. So this is a somatic motor neuron, and we can see this long communication directly onto the skeletal muscle, all myelinated. On the preganglionic neuron, we can see this communication again to the pre-ganglionic axon, ganglionic neuron cell body. Then we've got this post-ganglionic axon, which is absent of the myelin, so we don't have this myelin or as much of this myelin covering. Then this, of course, is going to go to the smooth muscle or glands in the visceral. Why is myelin so important? Well, myelin is very important if you think about fibre optics in your house, for your TV, for your your computer systems, in computer technology. The more covering in fibre optics, the higher the speed. And then this is why we're going to talk about demyelinization and some of the pathologies occur with that, and why in certain cases you need to have areas that don't have high speed transmission, because you wouldn't want to react certain areas within the body. So the subdivisions of the autonomic nervous system, we've got the sympathetic thoracolumbar division, preganglionic neurons in the lateral grey horns of the spinal segments, the ganglia near the spinal cords, and then the target organs, and of course eventually we're talking about fight or flight response. Parasympathetic craniosacral division, preganglionic neurons in the brain stem and the lateral portion of the anterior grey horn, S2, S3 and S4. Ganglion in or near the target organs, preganglion fibres, which are excitatory stimulating ganglionic neurons. These are going to go to the target organs. All postganglionic fibres release ACH at the neuroeffector junction. Of course, this is going to be the rest and digest, or rest and repose response. So let's just have a quick look at the autonomic nervous system. So let's look at the thoracosympathetic division first of all. We have the sympathetic division of the autonomic nervous system, the thoracic nerves, the lumbar nerves. Then we can see here the cranial division of the parasympathetic nervous system coming here via the cranial nerves, and then of course the sympathetic, which is going to come from the vagus nerve, and then the vagus nerve is going to come down via the carotid sheath, arch around the aorta, give off the recurrent laryngeal nerve. It's also going to then come off and give off various other branches all the way down the spinothalamic tract. There's a communication, an axonal body communication. Then we have the other part, which is from S2, 3 and 4. So the entirety of the parasympathetic is S2, 3 and 4 from down below, and from the cranium and from the vagus nerve up above. Okay, so I just want to talk about the sympathetic pathways to the peripheries, such as the blood vessels, and look at this in a little bit more detail. So axons leave the spinal cord in the ventral rootlets and roots, and passes into the spinal nerve trunk and follows the ventral anterior ramus to the right communicating ramus to join the sympathetic trunk ganglion on the sympathetic trunk. There, the preganglionic neuron either synapses with a postganglionic neuron, or travels up or down the sympathetic trunk to synapse with a postganglionic neuron in another sympathetic trunk region. So what does all of this mean? Well, we can just kind of see here. Here we have the ventral root and the dorsal root. Here we have the sympathetic trunk. Imagine that the sympathetic trunk is going up and down the entirety of the vertebral body. Then we have this communication via the grey rami communicans and the white rami communicans. We have the sympathetic trunk, which can then communicate downwards or upwards onto the next level. So the sympathetic trunk also gives rise to the splanchnic nerves, such as the thoracic splanchnic nerves, the greater, lesser, the least, which we've started to look at. And the splanchnic nerves are then giving rise to the viscera, so we're getting these various ganglions that we're going to talk about within the viscera. And the sympathetic trunk anatomically, we can see in our cadaver, which will, as we continue on through our disarticulation, we can look at the posterior thoracic wall and see the sympathetic trunk running bilaterally along the vertebral column. So it's running, or the ganglia are orientated along the length of the paravertebral region. So we can see this very, very important trunk running paravertebrally. So the sympathetic division consists of the following. We've got preganglionic neurons located between segments T1 and L2 of the spinal cord. We have two types of ganglionic neurons in ganglion near the vertebral column. We've got the sympathetic chain ganglia, also called the paravertebral because it's going parallel to vertebra, or the lateral ganglia. And then we have the collateral ganglia, also known as prevertebral ganglia. These are specialised neurons in the medulla of the adrenal glands. And here we can just see the preganglionic fibres, postganglionic fibres, and then the hormone release into the circulation. So here we can see the lateral grey horns of the spinal segments, T1 to L2. We've got the sympathetic chain, collateral ganglion, the adrenal, and we can see this postganglionic fibres, and then of course with the adrenal, because of it being adrenal, of course, we're going to have the hormone release, and this is going to release to the systems throughout the body. And with the case of the sympathetic chain and the collateral chain, we can see the visceral effectors in the thoracic cavity in the chain of the sympathetics, and the visceral effectors in the abdopelvic within the collateral ganglia. The sympathetic pathways to the head, so we have a slight difference when we think about the head and neck. We have the superior cervical ganglion in the neck, and then this giving rise to the axons of the arteries and the salivary gland in the mouth. So this is the visceral effectors of the head, and here we can just see the superior cervical ganglion, and we can see the traversing in relation to the arteries of the neck, the great arteries of the neck. So here we have the external and internal carotid arteries with the sympathetic parietal plexus. And remember as well that we're going to have the vagus nerve, which is coming down within this carotid sheath, and in this case we can see giving off the right recurrent laryngeal, and then we have these various ganglia. So as we move on to head and neck, we will start to talk about this in more detail. But here we can see the inferior cervical stellate ganglion, which is then going to come on and form with the thoracic ganglion, which we're going to see coming down the rest of the body. So the parasympathetic craniosacral division, again we can see the preganglionic fibres and the postganglionic fibres. So the preganglionic neurons, we have the nucleus in the brainstem, which are going to give rise to the ciliary ganglion, pterygopalatine, submandibular, optic, intramural ganglia, and then the various target organs, and then of course the nuclei in the spinal cord segments S2, 3 and 4. We're going to have these preganglionic fibres, which are then going to give rise to the intramural ganglia, which is going to give off these postganglionic fibres, giving off to the viscera and the organs of the portion of the abdopelvic region, which we shall look at in our cadaver. So let's look at the sympathetic neurotransmission and the parasympathetic neurotransmission in relation to pre- and postganglionic, and also in relation to myelization. So here we can see the sympathetic neurotransmission. We've got the preganglionic fibres, and we have the autonomic ganglion. We can see the release of the acetylcholine, and the postganglionic fibres, norepinephrine being released on the distal part of this. The sacral spinal cord, in this case, so this was the thoracic, this is the sacral region. We can see the parasympathetic neurotransmission, as we said, coming from S2, 3 and 4. We're going to have this preganglionic fibres, we're going to have this autonomic ganglion, acetylcholine release again, and then this postganglionic fibre, so much shorter as opposed to the sympathetic. Okay guys, well I hope that was useful, and this is the first part of a series of lectures to break down the entirety of the material, and as well as that we're going to add some cadaver lab sessions to this. Thank you for your time. Please email me or leave comments if you would like any additional information.